So I don't have any conflicts for this topic. So we are going to talk about, diagnosis, pathophysiology, some definitions that I think they are really important, like a fulminant IIH, refractory IIH, medical management, and surgical management. So let's start with the diagnosis. This disease was first described in 1893 by Quink. This is the same guy that described the needles that we use for lumbar puncture. So basically, he described patients with increased intracranial hypertension with basically normal CSF during lumbar puncture. The term pseudotumor cerebri was used the first time by an ophthalmologist known in 1904. And the same situation, basically patients with increased intracranial pressure. At that point, they didn't have CT, but most of the time they used pneumoencephalogram to, rule out any tumor. So Dandy in 1937 basically described few cases with increased intracranial hypertension and, ruling out tumor. So that's why they were using the term pseudotumor cerebri. And when we modify that criteria, is the one that we have now, is basically the modified Dandy criteria. Foley in 1955 used the term benign intracranial hypertension. But we know that not all these patients has a benign prognosis. Some of them even lost the vision, and that could be permanent. So that's why we don't use that anymore. So instead of using the benign intracranial hypertension, we use idiopathic. That basically means that we rule out other etiologies. In 1985, using CT, we have like a better way to rule out especially tumors or other pathologies that could explain the intracranial hypertension. So the modified Dandy criteria was postulated by Smith in 1985. That's the modified Dandy criteria. So we know probably all of the residents, all of the neurologists, we saw these patients, and most of the time they presented to us with headaches. But if they go to the ophthalmology department, they go with visually transient visual obscurations, or sometimes even vision loss. And that's the key part. If they have vision loss, most likely either the natural course is really fast, or they are dealing with these symptoms for a long term. Other symptoms include pulsatile tinnitus. Most of these patients go to the ENT, not to us, but it's really important. If you see the frequency of these symptoms are like for headaches, almost 90%, for transient visual loss or obscuration, about 80%, for pulsatile tinnitus, about 50%, for visual loss, about 30%. So 1/3 of these patients, the vision is threatened by this condition. There are some efforts in this trial to try to summarize an understanding of how these patients present, and basically it has the same frequency of the symptoms. We're talking about the modified Dandy criteria. So basically the idea is that they present symptoms and signs of increased intracranial pressure. We know that from any patient that is herniating, headaches, nausea, vomiting, with these transient obscurations. But the key part of this is papilledema, right? So unfortunately, I don't know how many residents we are here. How, are you, between 20 residents, how many residents are confident to diagnose papilledema on a fundoscopy? Yeah, probably one. So that's that's a lost skill on the neurology resident, unfortunately, it's reality. So, but that's important. So that means that if we see a patient when we suspect IIH, we need to refer to neuro-ophthalmology. There is no way that we can wait or, try to, well, maybe I will do a fundoscopy without any dilation. So there is no point of that. The exam needs to be non-focal. You can have bilateral 6-nerve palsy or unilateral. The CSF needs to be clear, normal, basically, except by the pressure, right? And we'll talk about what's the best way to measure the pressure in the LP. And usually rule out any mass. Obviously, in the original Dundee criteria, they use ventriculography. Then they use CT in 85, but now we use MRI. That's the main thing. As I was talking, papilledema is one of the key parts of this problem. But this is a normal endoscopy, and these are all the gradings. It's important that we need to be clear about this. We saw so many patients when they have the diagnosis of IH, they are on medications, they are treated. Some of them even they already lost part of the vision, but they don't have an ophthalmological evaluation. And that's the way that we see progression. Because the most, disabled part of this disease is vision loss. And papilledema is the key part of it. Same situation here, it is just talking about the same thing, symptoms, including all intracranial hypertension. If there is signs, needs to be related to this. Documented elevated pressure on, lumbar puncture, normal CSF, and there is some findings that we can see on MRI, empty cella, the optic nerve, but usually these are related to the IH. But that's also important. If you have a patient with meningitis and you do an LP, they will have headaches. Probably they will have papilledema, but the CSF will be abnormal. So that's not IH. So that's probably secondary intracranial hypertension. We have some patients that were referred to do, any procedure, whatever, but they have another reason why they have intracranial hypertension. So we, as a neurologist, we need to rule out this. So that's also a key part. There is a huge list of possible situations when we have secondary intracranial hypertension, like medical disorders, Addison disease, severe iron deficiency, heart failure, medication. So we need to get a really good med reconciliation. Some of these medications are really, they use for a long time. And then if we stop that medication, most of the time the intracranial hypertension resolves without any other treatment. Also, some anatomical structures like venous drainage could be affected, like a CVST or jugular vein thrombosis. So this is probably the most updated criteria to try to, standardize the diagnosis for IIH when you need to have papilledema, a normal exam, imaging, ruling out a tumor or other secondary condition that explain the hypertension, normal CSF, and an elevated pressure more than, basically 25 centimeters of CSF in adults and usually 28 in children. But also this is important in a properly performed lumbar puncture. Usually, our threshold is 20, but to diagnose usually is 25. Most of these patients are obese, so probably that change, is related to the obesity to try to also be more sensitive. Then we were talking about that most of the on this criteria, papilledema is important. Is there any way that we can diagnose IIH without papilledema? Any of the residents? Yeah, that's so. But so almost 95% of patients with IIH has papilledema. So if the neuro-ophthalmologist said there is no papilledema, there is still a chance that they can have IIH, but the chances are low, less than 1%. It's possible, but it's a red flag. If you see a patient with obesity, headaches, elevated intracranial pressure, and no papilledema, you need to say, well, what's going on? Something could be different, maybe medication, maybe other secondary cause. If you rule out everything, then it's possible, but it's really low. So That's the criteria by Friedman when he basically needs to fulfill radiological criteria, all these, and even and also 3 of these 4: empty cell, flattening of the posterior aspect of the glove, distension of the preoperative space around or a tortuous optic nerve, or transverse sinus stenosis, especially transverse venous sinus. So you need to fulfill all the other criteria except papilledema to basically diagnose this. And this is really rare. This is basically a observational study when they include 45 patients with refractory headaches, and they were suspecting IIH as a cause. They didn't have papilledema evaluated by ophthalmology and even OCT, and then they measured the pressure. The pressure was low in most of them, between 20 and 25, like kind of the borderline in 7, and more than 25 in 2. And then in those 2, only 1 fulfilled the criteria based on imaging. So in this paper, only 2.5% of these patients were diagnosed with IIH without papilledema. So that's really low. Okay, even with the high suspicious, they were having refractory headaches, they rule out any other condition. So most of the time, 95%, maybe 97%, these patients have papilledema. Something, obviously, you see the charts, they sometimes they don't document, or there is no evaluation by neuro-ophthalmology, so that's different. Doesn't mean that they don't have it, they were never evaluated. Some details about lumbar puncture, hopefully also this is not a thing that residents are losing, the skill, because we saw a lot of referrals to neuroradiology to get an LP. So I think also this is important for any neurology resident. You need to be confident to perform a lumbar puncture. What do you notice about this position for the residents? Yeah, how do you measure the pressure if the patient is on prone? You still can do it. This usually does the way that neuroradiologist does, but they need to add the size of the needle. So depend on obviously the preference. Some of them measure on the cubitus, but like most of them measure prone, and they need to add, the top of the CSF, they need to add the length of the needle. So one other thing, when we measure CSF, pressure using centimeters of CSF, is not equivalent to millimeters of mercury. So when we measure ICPs, with an ABD, whatever, we use millimeters of mercury. So it's kind of similar, but not the same. On our criteria, we have 25 centimeters of CSF. So that's our criteria. So we can do it. It's important for neurology residents to be confident to do lumbar punctures, Then let's talk about pathophysiology. But before that, anytime you see diagnostic criteria, that means that the understanding of the pathology and the pathophysiology is not really clear. That's why we have criteria. It's not like you have a stroke, you see a clue, you see a clot, you see a DWA change on MRI, and obviously there is no criteria for the stroke, right? But when you have criteria, that means that the pathophysiology is not clear yet. Hopefully at some point it will be. This is one of the first paper in 2007 or 16 to try to summarize all the mechanism, the possible mechanisms that are affecting this condition. So the main thing is that probably there is increased CSF production. How? Now we are understanding that maybe peripheral adipocytes produce some elements that increase this production. There is decreased, or reduced drainage of the CSF around the around granulations, likely related to, like kind of medications of obesity, and there is increased venous sinus pressure as well, and that's also related to obesity, increased thoracic pressure, and could be related to venous sinus stenosis. But that produced a cycle. So all of these increase the ICP, and the ICP as well, stretch the venous sinus, and that also increase, all these effects, and then it's producing a loop, a feedback loop that is continuously affecting the intracranial pressure and producing more symptoms. Now, this is a paper from, I think, a year ago, but basically it's trying to explain how centripetal adiposity could explain some of these problems. How they can increase the CSF production with basically these effects, also some hormonal effects, how they decrease the CSF reabsorption on the arachnoid, or producing intrinsic stenosis. Intrinsic means that basically the granulation is affected and there is a focal stenosis. So all the rest of the sinus is normal, but only this area is stenotic. Extrinsic is when the whole sinus is affected and you see the whole area is narrow. And now, in 2012, the lymphatic system was described, and now we are learning that there is some structures, including astrocytes and anticoagulating 4 channels that also could be impaired. And that basically go back to this area when you have that impaired lymphatic drainage. So multiple mechanisms are working in, to produce this symptom. And similar to the, lymphatic dysfunction, there is the lymphatic outflow obstruction, also in the nasal mucosa that is related. So this is a paper from a week ago in New England trying to, what's the best understanding now about this condition. So a patient usually with, obesity, headaches, and increased central venous pressure gain more weight, or maybe there are other factors, but that produces an increase in the dural venous sinus pressure. That reduces the pressure gradient for CSF flow around the granulation. So, any fluid goes where there is low gradient, right? Like any fluid goes from a high flow to a lower flow. That's the usual way. But if you have increased pressure, then that's affected. That also decreases the rate of CSF absorption, and that produces an increased ICP. The increased ICP probably compresses the dural venous sinus. Then that produces this focal stenosis is more affected on the transverse sinus and the sigmoid sinus. And this is a feedback producing more intracranial pressure. So we have a feedback, going in the same direction. So it's the same thing, but it was described like maybe 4 years ago or 3 years ago. But same thing, like CSF production, CSF drainage, and sinus stenosis. So this feedback. And what's the role of venous stenosis? Almost 95% patients with IIH present some venous stenosis in neuroimaging. Compared to controls, like a normal healthy patients with even obesity but without IIH, only 4 of them presents stenosis. So that means that it is related. At some point, we were, well, is the chicken of the egg? Is the stenosis the cause of the IIH, or is just the the effect of the intracranial pressure? We don't, as I mentioned, most likely now, the theory is that it's like a feedback loop that we are having. There are different ways of stenosis. There are different gradings. You don't need to know about this, but at least you know that most of these patients present stenosis on the sinus. Same, this is a MRV time of flight, and there are scores to measure that. Something to point, this is the area where most of the patients present the stenosis, between the transverse sinus and the sigmoid sinus. So this is the superior sagittal sinus, torcula, transverse sinus, and sigmoid. So This is the area when most of them present the stenosis. Sometimes could be bilateral. We're talking about two different types of stenosis. One is intrinsic, when there is a defect in the filling. So this focal, that most likely is a arachnoid granulation. But sometimes there is external compression, and we call extrinsic, that the whole transverse sinus is affected. Sometimes we see patients that in the hospital, they're admitted for vision loss. They do an LP. LPs, the opening pressure is high, maybe 30 or 40. They already, obviously, they will call us a code stroke at the beginning. They did a CT, CTA, and the CTA on our center is a monophase CTA, right? But sometimes we can see the veins. Ideally, we should have a arterial phase and a venous phase on CTA. We don't, but still you can see the veins. But then the next step when somebody sees possible IH is ordering an MRV. What do you think is the best test to see the sinus? Comparing, you have MRV without contrast, MRI with contrast, or CTV. What do you think is the best test to assess the sinus? Probably the second. That's the second. I will say MRI with contrast with 3D reconstruction. That's really when you can see the arachnoids, you can see filling defects, you can compare both sides. MRV is just a reconstruction. And if it's without contrast, it's reconstructing the flow. It doesn't tell you anything about the anatomical structure. So if you need to do an MRV, do it with contrast. But to rule out this, any tumor, any other secondary etiology, we need to do an MRI. So MRI with contrast, and obviously, pointing that you need a 3D reconstruction, it will give you the best imaging for this. CTV is good if you already, but the problem with our CTAs are we have monophasic CTAs. So sometimes you only see arteries and you don't see veins at all. Sometimes it's the opposite. You have a coded stroke and all the sequences are on the veins, and you see like a lot of contamination, and you don't know if it's arteries, it's vein. So that's why in other centers they have multiphasic or at least biphasic CTA. Hopefully we will fix that. It's just as a construction, but probably this is just to kind of to show in general. But the best way is to scroll and see each segment of the area. But this is a reconstruction from the MRI. So we diagnose this patient, so we have a patient with symptoms. We did LP, the pressure is high. We rule out any other condition. It's not a secondary intracranial hypertension. It's a primary or idiopathic intracranial hypertension. Then what's the management? So first, as we talk, we need to make sure that the patient doesn't have papilledema. So basically, neuro-ophthalmological referral is important. Inpatient, outpatient. Then second thing, we said that 95% of this patient has stenosis. So neuroimaging is important. The other reason why it's important is because we need to rule out cerebral venous thrombosis that presents similar, same symptoms, but in this case, it's secondary intracranial hypertension. So it's not idiopathic. So we need to rule out. Sometimes MRV, MRI, or CTV is enough, but sometimes we need to do an angiogram. Lumbar puncture, and then we rule out, and then the full diagnostic criteria. So then what's the next step? If the patient has visual loss, how long do you think medical treatment will start working for a patient? Imagine we just start diamonds right away. So you diagnose IIH, the patient already has vision loss. That was the cause of the, for the patient going to the ED. So we diagnose IIH, and then we start Diamox. When the Diamox will start working? Can you guess? At least 4 to 6 weeks. obviously some of them will not tolerate. If you recommend lose weight, get a bariatric surgery. How long it will take? Start anti-GLP inhibitor. Yeah, it will work, but that's the key part of the diagnosis. So we need to make sure that the IH is not fulminant. And this is a term that was started in 2007, to make sure that it's different when you have a patient with acute onset and usually less than 4 weeks of symptoms and with rapid worsening visual loss. So that's different from a regular IH. So this is probably only 5% of the patients. So 95% are fine. They're dealing with this for months, and you can send to the outpatient headache clinic, outpatient neuro-ophthalmology, start Diamox, and they will be okay. But 5% of them, they have fulminant IIH. And what's the problem with that? If you misdiagnose this, blindness. And that's the problem, because sometimes we see patients after, they were on the ED 3 months ago, they were still on Diamox, they are tolerated, they're doing okay, but then when you check the vision, it's gone. So then what's the point of doing everything else? So probably to prevent more vision loss on the other side, but at some point it's permanent. So that's really important for you guys, especially for residents, to don't miss this diagnosis, especially on the ED. When an optometrist sends a patient to the ED, seeing papilledema and vision loss, you need to take it, it's not just IIH. It will be fulminant IIH. So then, if you have this fulminant IIH, there are 3 options. You need to release the pressure right away. Options is you can do several lumbar punctures, like every day for 3 days, but that's unpractical. Most of these patients, even just to getting an LP is difficult. So imagine doing LPs 3-4 times every day. So we have surgical options. Probably the most effective one is BP shunt. So you need to call neurosurgery for BP shunt, or optic nerve fenestration with neuro-ophthalmology. But in the acute setting, in the inpatient setting, not referral as an outpatient, right? Or we have an option to do a venous sinus stenting. And for stenting, the effect to decrease intracranial pressure is also, it started almost at the same moment that you deploy the stent. Obviously, you advise to weight loss and all the other things, but if you have fulminant IIH, you need to do this. What's the problem with this, with the headaches for these patients? Their comorbidities are, the proportion of comorbidities, including migraine, tension, headaches, medication overuse, is almost 90%. So our focus is not headache for us, at least for neurologists. Sometimes it could be frustrating because these patients, you do everything and they still have headaches. So probably they have other comorbidities. So headache neurology needs to be involved for this patient as an outpatient for sure. It's important because you will not cure, even with Diamox or whatever medication, you will not treat the headache. All these patients need to weight loss. Now with the anti-GLP, hopefully most of these patients, obviously, will not need any maybe surgical management. They just published a paper like 3 weeks ago saying that the use of anti-GLP inhibitors decrease the need of these procedures. But we'll see. And then obviously, if the patient is stable, you can have a follow-up. From our perspective, it's hard to know, if there is a threat for vision loss. But if you do your Snellen, evaluation, and you see that the visual acuity is less, that means that the optic nerve is already damaged. So you need to take that in consideration. So obviously, you will not do a fundoscopy, but you need to evaluate visual acuity for all these patients. We are not talking about, campimetry, right? So that's different. That could be related to papilledema, optic nerve, but visual acuity, that's the key part. And obviously, ophthalmological evaluation. Then we have a patient that is stable, is not fulminant IIH, is yes IIH. You start treatment, you send this patient to the outpatient clinic, headache, neuroophthalmology, but there are some options, They still have progressive visual field loss. So even that you start treatment, they're still having more visual field loss. Or the papilledema is not improving after 4 or 6 weeks. So usually in 4 weeks, the papilledema should improve from the grade 4, maybe grade 2. Papilledema doesn't mean vision loss. Okay, papilledema is just edema on the optic nerve. But if that is not improving, regardless of the medication, that's called medically refractory. Or they have recurrent papilledema. Or the other option is that they don't tolerate this medication. But when you use these medications, I don't know, what's the dose when you start Diamox in the hospital? 500? Usually you start low and then you add, you increase the dose the next day or 2 days, sometimes you check. But in order for the medication to be effective, it needs to be at least 1,000 once a day. Most of the time, you start at 250 BID, then you go up to 500, and then at some point you get this goal. But not all the patients achieve this goal. If you are getting 250 BID, the medication, it doesn't mean it's not working. It's not at the same level. It's not at the level that it's going to work. Say for Topamax, it needs to be at least 200 daily in order to consider that this medication is not working. Either we get to this goal, or if the patient is not tolerating, then we need to call refractory or medically refractory IIH, and we need to do something about that. So that's key as well. So we were talking that stenosis of the sinus plays a role in the pathophysiology of this condition, but the same as, for example, any other disease, epilepsy. How many patients with refractory epilepsy need surgery? Will you guess? We have epileptologists here. Yeah, probably less than 10% for sure. But how do you know that? Do you think, well, this patient has refractory epilepsy, let's do surgery right now? No, we need to assess, right? You need to do evaluation, EMU, all these things. Same for Parkinson. How many patients with Parkinson disease needs DBS? Not all the patients, right? Same situation here. Not all the patients with IIH needs any surgical treatment. Maybe only 5%. But you need to assess which one benefit from these procedures. So that's the key part. So there are some conditions that could mimic IIH. In medically refractory IIH or fulminant IIH, I think it's key to do an angiogram. Not just a venogram, an arterial angiogram, because you can have a fistula with venous congestion and could produce the same symptoms. Also increase, and sometimes you don't see this in just non-invasive imaging. You can have an AVM. There are different other conditions, fistulas, AVMs, that could mimic an IIH. And also, when you do the arteriogram, the late phase of the arteriogram is the venous phase, and we can see the sinus there. But the most important part for us, even if the patient has stenosis, is to make sure that there is a difference in the pressure between the distal vein, this is superior sinus, and probably the proximal area. We call that gradient, so basically the difference between the pressure. This is a patient who already has stenting. So you see the stent is here, but you see the gradient was higher before and now it's better. Usually, there are two separate things. If the patient has a fulminant IIH, the patient needs treatment right away, regardless of the manometry. So either BP shunt, either optic nerve fenestration or venous stenting. For patients with medically refractory IIH, we usually perform Sinus Manometry to see this gradient. And most of the time, this is elective. if the patient is already in Diamox, we need to stop that for at least 3 days. Usually, if the LP was done already, we need to wait at least 2 weeks. And the reason for that is because after LP, you have CSF leak normally, right? So the pressure will be low. And then if we're measuring pressure, will be false negative. Basically, we have normal pressures, but they are not real. Usually, anesthesia needs to be just lidocaine, usually just local anesthesia. We can do either using the arm or using the groin. This is the size of the catheter that we use. And these are kind of the measurements that we have. As I mentioned, we can use the arm. We use the superficial veins, the cephalic artery, the basilic artery, or you can use the femoral vein, going to the inferior cava and going to the IJ and then going to the sinus. These are basically the mean pressures that we have, but at the end, we compare or we measure in all these areas: the superior sagittal sinus, the stercula, sigmoid, IJ, and our focus is to see if there is gradient. Especially if we have focal stenosis and we see gradient, that means that the flow in this sinus is affected. And even if it's the cause of the effect, that will change this feedback loop, and that will improve patient symptoms. But the most important thing is to decrease the risk of vision loss and papilledema. Most of the time, the area that is with more gradient and more stenosis is the same. The junction between the transverse sinus and the sigmoid sinus. These are basically different catheters that we use, but basically the same as measuring ICP. When you have an EVD and you connect, same thing, or like a central line and you measure ICP. So basically, you get the catheter either from the arm or from the groin. You go to the place that you want, and then you connect to this monitor, and you have a wave on the monitor, and you have a number. These pressures are usually in millimeters of mercury. And then what's the threshold to recommend stenting? So there are a lot of papers, but most of the reviews, like this is a systematic review of about 200 patients, consider that a threshold of 8 millimeters of mercury, so a gradient of 8, is enough to see that this patient will benefit from stenting. So this is the improvement. If you have this threshold, it's 87. You can say, well, what if we increase the threshold and go to 21? Obviously, you will get better results, but you are missing some of these patients. So some of these patients are missing the treatment. The same with thrombectomy. Obviously, if you are more specific with the disease, you are getting maybe better results, but some of these patients are not they are not getting the benefit from the treatment as well. So you need to have a balance. But most of the, recommendations are like 8 millimeters of mercury at least. So we briefly talked that there are 3 or 4 surgical options. So first one is probably, and the most effective one is BP shunt. That's the easy way for us to do, say, well, yeah, go to neurosurgery, let's place a shunt, and we'll go from there. So the problem with BP shunt is that it has like a failure of almost 40% in the next year. So, and they need to review the shunt, they need to change the valve, and somebody even they need to take it out. So the complication rate is high. It's easy to place at the beginning, but to follow up is difficult. Next option is optic nerve penetration. So basically, they open the skull, they go to the optic nerve, and they release the sheath of the nerve. It's an invasive procedure, but if it's needed, you need to do it. Also, the complications rate is about 2%, or even probably 3%. Bariatric surgery is also another option, but unfortunately, it's not that available option, especially for patients, without insurance, all those things. They need to I don't know how many patients that we deal on the clinic with, obesity or comorbidity get bariatric surgery. So it's not easy to get, and the complication rate is high, about also 30%. So then an alternative is sinus stenting. It's not invasive, similar results with less side effects. So it's an alternative. Probably the gold standard will be VP shunt, but not all the patients, unfortunately, will get a VP shunt, and almost 30% they will need to review the shunt, or they will have any complication. So these are meta-analysis reviewing this how the papilledema improve after venous stenting, and you can see that there are several reports. Unfortunately, we don't have randomized clinical trials yet. All the evidence is from observational studies. So, and this is a review of most of the studies that we have, and you see the number of patients is not a lot in each trial. In this review, it was about 800 patients. That was published like a year ago, but the effect is about 90% for papilledema with low complication rate, usually less than 2%. That's kind of the way that you can see improvement. Obviously, the neuro-ophthalmologist will see that. So after this, a patient that got a shunt and stenting, but the shunt was not working, and the ophthalmologist will tell you if there is improvement on papilledema. Headaches. This is a review saying that probably similar studies with less, it's less effective. Here I mentioned about 80%, even probably it's less. When we usually consent these patients for venous stenting, what's our outcome? So most of them is basically papilledema improvement. Headaches could be, but usually these patients have other comorbidities like migraine, and basically they need a neurologist to treat the headache, because most of the headaches are not related to IIH. Probably some of them, yes, but not all. So we need a multidisciplinary approach for this patient. So neurologist needs to be involved, neuro-ophthalmologist needs to be involved, and any neurointerventional needs to be involved. At the beginning, we said that pulsatile tinnitus could be present in about 50%. Sometimes these patients don't have papilledema, but that could be disabled. Imagine hearing one sound every second of your life, and the sound that they hear is really bad. So venous stentings also could help this condition for selected patients, not for everyone. So obviously, we need to talk with ENT in this case, rule out any other conditions that could explain this. Diplopia and visual disturbance also is effective, about 80%. And we're talking about the complication rates of optic nerve fenestration, about 2%, shunting in general 10%, bariatric surgery about 30%, and venous stenting about 2.3%. So if you think about that, optic nerve fenestration and stenting is almost the same, but to do an optic nerve fenestration is a craniotomy. So you need to open the skull. It's an invasive procedure. Venous stenting, you got basically a stick on the groin or the arm, 2 sticks, one for the artery, one for the vein, and recovery is really fast. You go home either the next day, usually. Obviously, any procedure has benefits and risks. But in this case, the risks are around 2 to 3%. And these are kind of the recommendations from some of the societies about which patients need neuroimaging. Basically, I will say neuroimaging for all IIH patients. If they have medically refractory symptoms, they will need a venogram with venous pressure manometry. Obviously, all of them needs to measure this pressure on LP. Manometry. Arteriography basically is reasonable to rule out other conditions like a fistula, AVMs. When we do manometry, we usually do local anesthesia. When we do a stenting, we need to do general anesthesia because it's painful to deploy the stent in the sinus. The brain doesn't have nerves. You don't feel the brain, but you feel the dura. So every time you stretch the dura, you feel the pain. They feel really bad pain. And even after the venous stenting, we use sometimes steroids or opioids or even lidocaine intraarterially to try to decrease the pain after the venous stenting. And the microcatheter that we use. And last thing is obviously it's a stent. They need somehow of antiplatelet therapy. So when they started with these, they were placing dual antiplatelet therapy for 6 months to 1 year. But now there are a lot of evidence that 3 months is enough. It's comparable. They're comparing 3 months and 6 months, and they have similar effects. Even some centers do just 1 month of dual antiplatelet therapy, and after that, they just continue aspirin. So usually we start aspirin and Plavix 1 week before the surgery. We check ARU and PTY12. Everything is good. Do the stent. Keep aspirin and Plavix for 3 months. At 3 months, we repeat another venogram and measure the pressures. If the pressures are good, basically we stop. Either we stop both, or you can stop Plavix and continue baby aspirin for a year. You don't need like a live aspirin. These patients are young. Usually they're on the 20s, 30s. So you don't need to continue aspirin forever. At least 1 year with one of them. I think that's, and we're almost on time. So if you have any questions. Yeah. Yeah. Yeah, that will. Yeah, that's the problem with any randomized clinical trial. So as I said, only 5% of these patients has refractory medically refractory IH. So most of them medical treatment is enough, and from them you have, as you mentioned, 4 arms to do surgical treatments, or at least including bariatric surgery. That's why it's really hard to have a high 1A evidence. That's why we only have either prospective or retrospective observational studies. That's the difficulty to getting a randomized clinical trial for this. But as I said, it's medical judgment, right? So obviously, if you have a patient, you start, Diamox and anti-GLP inhibitor, and they are doing fine, and there is no, the papilledema improve, they don't need surgery. But if you have the same problem, you start Diamox, you start anti-GLP, they lose weight, and they still have the papilledema or the vision loss, they need something. Then they need either bariatric surgery, if they can get it, BP shunt, but they have several options to choose. And from these options, probably the non-invasive one and comparable effectiveness is the venous stenting. That's the way that I see this. Yeah. I didn't review with detail that part. I was trying to, just to show you that there are different medications that we need to rule out. If you go, to some of the papers, there are like a list. In general, if you think that that's the culprit, you need to remove it. If you don't think that's the culprit, probably not. But it's the same, with myasthenia gravis. You have a list of 30 medications. It doesn't mean that all these medications will affect, but you need to have your clinical judgment at some point. Yeah. Yeah, probably will get like a more estrogen is, they have higher chances of producing intracranial hypertension, but it's hard to, to know that. You can discuss with the patient and see if there is any alternative, like a DUI or DIU, that is good to consider that. Hey, Robert. Yeah. 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 Yeah, but that was that statement was for elective venous manometry. If you have a fulminant IAH, you need to release the intracranial pressure right away, either with a BP shunt, either with an optic nerve fenestration, or venous stenting, regardless of the venous gradient. So if you any or even like a consecutive lumbar or lumbar drain or consecutive lumbar lumbar punctures. So for fulminant IAH, you don't need the gradient because you already know that the pressure is high. Obviously, you need to rule out any other conditions, like, for example, um, CVST, like cerebral venous thrombosis, is producing that, but you need to release the pressure right away. And stenting is still an alternative for these conditions. So probably the most effective one and the one with more, you see the improvement right away will be BP shunt. Probably that's the gold standard. And then probably optic nerve fenestration and venous stenting. So venous stenting is an alternative for that. But if you do a stent for that condition, for fulminant IH, you don't need the gradient. So you don't need to wait these 2 weeks. For elective, if the patient is stable, but it's medically refractory, then you need to at least wait 2 weeks just to make sure that you don't have the leakage from the CSF and the pressures that you are measuring are not, false negative. Yeah, we saw not a lot because it's an alternative. So as I said, if the patient, basically it's a multidisciplinary discussion, right, between neurology, ophthalmology, and neurosurgery or the neurointerventional team to discuss what will be the best, and effective treatment. Some patients doesn't, they have other comorbidities, and BP shunt is not an option. So some of them also optic nerve fenestration is not an option. Then will be BP, venous stenting. It's an alternative for fulminant IIH. But the thing is, we need to do something when the patient comes with visual loss and IIH on the ED. I saw a lot of patients referral to from the outpatient setting. They were in the ED 3 months ago, but now the vision is gone. They're almost blind. And then they call for BP shunt or venous stenting, but what's the point? So I think that's the key part about talking about fulminant IH, that for the residents especially, that be aware that that could happen. It's not just IH. Oh yeah, IH diagnosed, go home. Yeah, yeah. As I said, part of when we do the venogram, we do first arteriogram to rule out any mimics. And one of them is dural AV fistula, dural AVM. That could explain almost whole symptoms, has the increase in the cranial pressure. That's the first part. So we need to rule out this. Yeah, it's the same time, same procedure. Obviously, we can go femoral, groin, or radial, but we have arterial pictures and then venous. So basically, the pictures for the veins and the arteries come from the arteries, but when we measure the pressure, we go from in the vein. Dr. Fracker, yep. Yeah, I will say that on the ED, we need to, be clear that unfortunately we are not, our fundoscopy skills are not good enough. So we need to get an ophthalmological evaluation. So in the ED first. And also if during, if we are getting the visual acuity is affected, that's a red flag. So if that's a red flag, needs to be something. So, and then it's a, as you mentioned, like it's a multidisciplinary discussion with ophthalmology and neurology at that point. If it's a fulminant IH, then we need to do either BP shunt, optic nerve fenestration, or venous stenting. I will say that the rate of, at some point, optic nerve fenestration was the trend, was the first surgery, even before BP shunt, but now not anymore. It's kind of, now venous stenting is getting more acceptable and it's showing similar results and with less side effects. And obviously, if you talk with a patient, like imagine a 23-year-old female on the best of her life getting a cut of the skull, and then you have an alternative to do a venous stenting, and with similar effect and with similar efficacy. So that's kind of, at the end, it's a discussion between the patient and the other teams. But yeah, I think the main idea is make sure that the vision is not affected. And we're not talking about, visual field. We're talking about visual acuity. Oh. No one. Is that the one? Okay. Thank you, guys. Thank you for coming. Thank you for your time.